All right, now we're going to do our neuro assessment. First thing you do in a neuro assessment is you check the patient's mental status. Of course, you can see she is alert, she is oriented, and hopefully very cooperative. First thing you will do is we'll check the cranial nerves. Cranial nerve number 1, the olfactory nerve, is the patient's sense of smell. What you could do to check the sense of smell is have the patient close their eyes. You could use different foods, familiar foods, easy smells to see if the patient's first cranial nerve is working. You can do that by having the patient hold one nostril, smell, and the same thing with the other. The next one is the optic nerve, cranial nerve number 2. You can check the cranial nerve number 2 with visual acuities, visual tests. Cranial nerve number 3, 4, and 6 is the oculomotor. You can check that by doing just a simple test, making sure that the patient can move her eyes in all directions without any problems or nystagmus or anything like that noted. So, Lily, I'm going to have you look at my finger. Okay, and I want you to follow my finger with your eyes and not your head, okay? Good. And that's those nerves are intact. So you can do that, check that by making like a big H with your fingers, making sure the patient can look side to side and up and down. Next thing is cranial nerve number 5, which is the trigeminal nerve. You can do this. You can have the patient clench their teeth. You can clench your teeth for me. Bite down real hard. Good. So those are the motor skills. Patient, can you lift your eyebrows? Lift your eyebrows. Good, and they're good and symmetrical. You can also check the sensory with the trigeminal. You could take a cotton ball. We'll use the back of my finger, and see if the patient, can feel that. Feel that? Feel that? You can also take it kind of towards the patient's eye. Yep. Oh, she's got a blink reflex. Oh. All right. So that nerve is intact. The next one is cranial nerve number 7, which is facial nerve. So you can check the motor. I kind of already did that. When the patient smiles, smile real big for me. Good. Make sure she doesn't have a facial droop or any unilateral weakness. Very good. Very good. Okay. You can also check sensory, different tastes. Next one is cranial nerve number 8, which is acoustic. That's hearing. You can do that by hearing tests, whispering tests. I think that's intact. Lily's hearing very well today. Next one is cranial nerve number 9 and 10, the glossopharyngeal and the vagus nerve. We can check this. You can have the patient open their mouth. We're going to open your mouth and say, ah. Good. The uvula is midline, but the soft palate moves up equally. You can also check the patient's gag reflex as well to check and make sure that nerve is intact. Next one is cranial nerve number 11, which is the spinal accessory nerve. You can check that by have the patient look straight ahead. Okay. Now, Lily, I'm going to have you try to look at that wall over there while I'm pushing on your chin with your head. Try to push your chin against my hand. Push it as hard as you can. Oh, good. Now do that on the other side. Excellent. And so that nerve is intact as well. Cranial nerve number 12 is the hypoglossal nerve too, which you can check that by checking different tastes, having the patient stick her tongue out, and that nerve is intact. All right, next thing we're going to do, you check the motor systems. You check for any muscle weakness. You can do things like have the patient raise their arms up, hold them up without letting them fall to the ground for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Excellent job. Grab my hands for me. Squeeze as hard as you can. Very good. You're very strong. Very good. And it's equal bilaterally. We did most of these tests when we did the musculoskeletal assessment. Next thing we're going to do is we're going to check the patient's gait and balance. So Lily, go ahead and stand up for me. Usually you would do this 10 to 20 feet, walk away from you and then walk back to you, but we just have a small space here, so. All right, I'm gonna have you just take normal steps. Actually, we'll just do it this way. So just stand up straight, please, for me. Okay, just walk normally to that wall and turn around and walk back. Very good. Her gait and balance is steady. No ataxia noted. We can check what's called a Romberg test. We'll have the patient stand there. Stand there with your legs together, good. And I want you to close your eyes. And we'll count to 10 for this test. Make sure she can keep her balance. Close your eyes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. So no wobbling or anything noted. She did not lose her balance. Now I'm going to have you walk heel to toe. You know how to walk heel to toe? I want you to turn towards that wall and walk heel to toe in a straight line for me. Heel to toe. Now put your heel. Come here. Heel to toe. That's okay. Walk. Turn around this way. Okay, now put your heel to this toe. Put this heel. Now this heel to this toe. But you walk heel to toe. Okay, I'm going to demonstrate for her. All right, watch me. Okay, ready? Go. Heel to toe, heel to toe, heel to toe. See how I'm doing that? Okay, now I want you to do that. Okay. Very good. Now walk back. All right, a little bit of imbalance. Lily has been treated for tightenings of the tendons, Achilles tendons, has a hard time standing flat foot. So I think that is what has gotten her off balance a little bit because she has a hard time getting off her tiptoes. Okay, first thing, now I want you to stand up on your toes. Very good, you don't have a problem with that. Now I want you to stand on your heels. Stand on your heels. Very good, very good. That's a little harder, isn't it? Okay, and now just a shallow knee bend. I just kind of want you to stand there with your feet apart a little bit. Just kind of bend your knees a little bit more. Okay, now stand up straight, and back down, and bend your knees again. Bend a little bit more. Bend those knees. Good, very good. Okay. All right, now you can sit back down for me. Okay. Next thing we're going to check is the finger to nose test. Okay, yeah, you like that? So I'm going to have you touch your finger to my finger and then your nose, and then again. Good, and again. Very good. Now go real fast. Touch your finger to your nose. Excellent. Good. There was no ataxia. She didn't have a problem with that. Normally you would check that with both hands. When we're checking the finger to nose, I was also doing kind of a rapid alternating movement as well. You can have her do it fast, see if she can keep up without any ataxia as well. Next thing is something called a heel to shin test that can also check for ataxia of the legs. So I'm going to have you lay down. Put your head on this pillow for me. Now I have you take this heel right here. Straighten out your legs. This heel and place it on this, and right under this knee. Okay. Now I want you to rub it all the way down your shin and back up. Now do it again. Put your heel, make sure that heel's on your shin. Good. Very good. Now back up. Good. So that's good. So heel to shin is normal, and you would do that with both legs. Very good. All right, now you can sit back up for me. Scoot your toot. Very good. We'll check sensory function. You can check that by doing sharp or dull. You could take a tongue blade and you could just break it in half and use the sharp end. You could check the patient's arms, but you would want to check it equal on both sides. Kind of touch it with the tongue blade. Let the patient tell you if that's sharp or dull to her. Check it again on her other arm, sharp or dull, and it should be the same on both sides. But you could do that on arms and legs as well. Next, you could do tactile discrimination, which you could use a cotton ball to do that. You could have the patient close their eyes. Okay. Now, when you feel me touch your arm or cheek or anything like that, I want you to say now. Okay? So close your eyes.
Now. 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 Now.
Good. No tactile discrimination. Next thing you do is check something called a vibration test, which you could do with a tuning fork. You could hit it on your hand. You could place it on the patient's fingertips. They should be able to feel the vibration from that, and it should be equal on both sides, which you could also do the bony prominences on the patient's toes. Make sure they can feel the vibrations equally using the tuning fork and placing it there. The next thing is position sense. So what you could do is you could have the patient's hand. I want you to close your eyes, and you could move the patient's finger, and I want you to tell me if I'm moving it up or down.
Up, down, up, down.
Very good. The next thing is stereognosis. This is something where the patient can recognize objects with their eyes closed. So we put like a penny in her hand, or a paper clip, a cotton ball, and see if the patient can tell you what that is she's holding with her eyes closed. The next thing is graphesthesia. You can do this by having the patient close her eyes, and you draw a number on the palm of their hand, and they can tell you what that number is. So I want you to close your eyes, Lily. Now I'm going to draw a number on your finger or on your hand. I want you to tell me what it is. Okay, so keep your eyes closed.
3.
Very good. So, and that's intact. That's good. 2-point discrimination. That's when you can straighten out a paper clip. You could use that and do it's kind of like the sharp or dull thing. You can kind of place that, use the straight end as your sharp, and just you take your paper clips and you can touch them on 2 different spots and have the patient close her eyes, and you can keep moving those together until the patient says now, and that means she could no longer, separate the two. That once they got so close, it just felt like one stick. And then extinction. Extinction is when the patient can neglect one side. Sometimes this happens in stroke patients. The patient just completely doesn't feel anything on this side, isn't aware of what's going on one side. A lot of times you would have to go around to the other side of the stretcher to talk to the patient, because if you were over on one side, that they couldn't hear you, so that's extinction or neglect. All right, reflexes, deep tendon reflexes. I don't have a reflex hammer with me, so we'll kind of improvise with that today. First thing, you would check the biceps. The way that you could do that is you could hold the patient's arm and just have it relax in your hand, kind of, and push there, right there on the middle. And then you could take your, your reflex hammer and just kind of tap it. Kind of just relax your arm. You would tap it, and you would see the patient's arm move if their reflexes were intact. Next thing is the triceps. You can hold the patient's arm out like this and hold it up like this and use the hammer to hit right above the elbow, and the patient's arm will jerk if that's intact. The next thing is brachioradialis. That's where you can hold the patient's kind of thumb up and out and let the fingers dangle and hit the hammer right above the wrist there. Next thing is patellar. That checks the quadriceps, or it's called the knee jerk. So we're going to have the patient, she can lay down for this, so go ahead and lay back down for me. And the patient's kind of scoot back just a little bit. Scoot back that way. Okay, good. If the patient's not sitting up, you can do this by holding, your hand kind of here and letting your patient's leg rest on your hand or arm, and then just and take your hammer and hit it right below the knee, right below the patellar, and you should see a reflex in your patient. Okay, I want you to sit back up for me. Next is the ankle jerk, or the Achilles reflex. Scoot your tooth back again. Very good, very good. Okay, that's where you just hold the leg, make sure the leg is relaxed, and you can just take your hammer and hit it back on the Achilles, just barely tap it here, and the patient will have a reflex. And then if you're checking for clonus, which is hyperreflexia, a lot of times if you have the patient lay back and you take, just kind of relax their foot, and then if you dorsiflex it back real fast, then their calf, their muscles can start jerking, and that's called clonus. Next thing you can do is you can check the abdominal wall reflex. The way you would do that is you could take your thumb or finger, the back of the hammer would be fine, and just kind of rub it in towards kind of midline in. And usually the patient's umbilicus will come up kind of towards the stimulus. So you would go up with that and then down. And then the next thing is a plantar reflex. Go ahead and scoot back for me a little bit more so I can get your foot in the picture. Good, good. Just have the patient relax, and you could take your finger or the hammer and just kind of rub it in an upside down J. Ticklish, aren't you? And see how the patient's toes fan in like that. That is normal. What you don't want to see is when the patient's feet flex back and their toes spread out like a monkey. That is an abnormal sign. So you do want the patients to kind of come forward and the foot to kind of go back. All right, and that's it for our neurologic assessment. Thanks.